Thank you, everyone. My name is Sheng-fu Larry Lo, and I'm the Director of Spine Tumor Surgery and the Co-Director of Spinal Deformity Surgery at Northwell Health. And today I'll be talking about osteoarthritis of the spine, all you need to know. These are my relevant disclosures. They are not relevant to this talk. In terms of the learning objectives of today's lecture, basically, spinal osteoarthritis tends to be a quite generic term that refers to a lot of different pathologies. So I'll go over the more commonly heard terms and describe sort of what they actually mean and what the clinical implications are. So we'll start off by talking about some basic spine anatomy so that we're all on the same page with regards to different parts of the spine. We'll learn the terminology used to describe different forms of spinal osteoarthritis. We'll go over sort of the presenting signs and symptoms, the epidemiology and risk factors for spinal osteoarthritis. And finally, we'll provide sort of a broad overview of the treatment options and strategies that are available to treat neck pain and low back pain. So starting off with the terminology, what is osteoarthritis? So it's basically a slowly evolving joint disease characterized by gradual development of joint pain, stiffness, and limitation of motion. It can basically occur in any part of the body, such as your elbows, your knees, your hips, as well as your spine. And it turns out that spinal osteoarthritis is quite common. If you look at the prevalence of lumbar or low back osteoarthritis, the estimates range from 40 to 85%, meaning that at any given point, 40 to 85% of the general population actually has symptomatic low back osteoarthritis or low back pain. So going over the basic anatomy of the spine, it's basically the spine is a complex movable column that's divided into sort of two major sections. There's the mobile spine, which is mobile, of course, and then there's the fixed spine, which is rigid. When going over the mobile spine is basically three sections. There's the cervical spine, which there are 7 cervical vertebrae. There's the thoracic spine, which is, there's 12 thoracic vertebrae. And finally, there's the lumbar spine, which there's 5 lumbar vertebrae. Basically, the cervical spine is your neck, the thoracic spine is your mid-back, and the lumbar spine is your lower back. And then beneath the lumbar spine, there's basically in the sacrum, as well as your coccyx, which is basically fixed, meaning that it is not mobile. Essentially, the primary objective of the spinal column is basically to protect the spinal cord. So if you look at this model, you can see that there's the orange structure that's running actually within the spinal column itself. And just to orient the audience, this is the back, this is the front, this is the head, and this is the feet. And you see that basically the spinal column circumferentially protects the spinal cord, and that's one of the primary functions. And another function of the spinal column is to basically act as the center of our body to provide structural support, such as to the ribs and to the organs, because it's basically in the center of our body. And at each of the spinal levels, there's actually 3 joints. So sort of focusing on the lower back here, in the front of the body, you have the disc, which is basically the most obvious joint. And then in the back of the body, you have paired joints in the back called the facet joints. So at pretty much each of the spinal levels, there's basically 1 disc space and 2 facet joints. So basically there's an L4-5 disc, and there's the L4-5 facet joint on the left and on the right here. So the facet joints, and then the disc. So going over each of the sort of the different regional anatomies. So starting off with the cervical spine. So basically the cervical spine is much smaller because it bears a lot less weight. All it's in charge of is holding your head up. And basically the occiput C1 and the C1, C2 joint is probably one of the most complex joints in our body. So on this model, the head is the occiput, the back of the head is not on this model, but basically between your occiput and C1, it's basically responsible for approximately 25 degrees of flexion and extension, meaning that it turns your head back and forth. And then between C1 and C2, so this is basically C1 and this is C2 here, it's responsible for about 30 degrees of head rotation. So basically, a lot of the majority of your head movement is really focused across this OC1, the occiput C1, and the C1, C2 joint, which is why the anatomy there can be quite complex. Moving on to the thoracic spine, these are basically the middle of the spine. And basically, there's 12 thoracic spine vertebrae. And this is a very uncommon area to basically get degenerative spine disease or spinal osteoarthritis. And the reason why is that it's typically a very stiff segment. As you can see on the diagram, there's basically 12 paired ribs that are further stabilizing the thoracic spine. So it's much more rigid compared to the cervical spine, the neck, or the lumbar spine, the lower back, which is why you don't commonly hear about spinal osteoarthritis of the thoracic spine, although it is something that we can see. And finally, in terms of the lower back, the lumbar spine, you can see on this model that the bones become much bigger, and the reason why is that it bears a lot more weight. Basically, the bottom of the lumbar spine basically bears the weight of the top half of your body. And again, just sort of go over the specific joints that are involved at each of the lumbar vertebrae. We have the disc space in the front, as you can see on that diagram. And you can also see the paired facet joints in the back. And this is predominantly where a majority of the spinal osteoarthritis occurs. So one of the common things that we hear the most in practice is basically this terminology, degenerative disc disease. So what does that really mean? So basically, as we age, it's a normal process of aging that we lose water in the disc. And basically, as we lose that hydration in the disc, it develops cracks over time. So what you can see is that a healthy lumbar vertebrae is well hydrated, nice and plump, and it doesn't have any cracks. And then as you age, you see on that second disc right there that I'm circling, that there's basically small cracks in the disc. And as a result of those small cracks, the disc loses elasticity and it becomes a little bit more stiff. As the spinal degeneration progresses, you can start getting bulging discs now, where you can see that in that third disc space right there, you can see that rather than being completely contained within the spinal column, you have bulges that starts bulging out. And what can happen over time is that you can actually get tears in the lining that covers the disc space called the annulus fibrosus. You can actually have a frank disc herniation right there, as I'm circling, where a small piece of the disc that's supposed to be contained within the disc space pops out into the spinal canal. And it's not the spinal canal is actually not the only area where the disc can herniate out. So if you look at this middle panel here, you can actually have the disc pop out to within the bone, and we call that Schmerl's node, and it causes exquisite back pain for patients. So if you look at sort of healthy population studies, 15% of all spines actually have some evidence of a disc dislocation. And if you look at the locations where it tends to occur, it's what you expect, which is the base of the lumbar spine at L4, L5, L5, S1, and the base of the neck at C5, C6, C6, C7, which basically bears the most weight. So on this model, it would basically be these two discs, the L4-5 disc, the L5-S1 disc, and then on this model, it would basically be the C5-6 and the C6-7 disc. And basically that's because it's at the very bottom of the weight bearing, so it's subject to the most mechanical stresses. Another terminology that we commonly use or we commonly hear is called spondylosis. And it's basically just a very broad term that describes any manner of spinal degeneration. So we already went over one manner of spinal degeneration, which is disc degeneration. But another very common form of spinal degeneration is basically the formation of bone spurs. The medical terminology of that is called osteophytes, but it's basically abnormal calcifications or hardening of the bone that develops with aging. So if you look at this panel right here, you can see that that's a nice, healthy spine. It's a smooth edge in the front without any protrusions or bone spurs, whereas you can see that as you age, you get these sort of spicules or triangulations that are bone spurs or osteophytes coupled with disc degeneration. So if you look at, again, sort of general population studies, 95% of our general population have some evidence of spondylosis by 79 years of age. So it's very, very common. We've been predominantly focusing on the front part of the spine or the anterior column, but you can also have degeneration on the back end of the spine where the facet joints are. And basically, our understanding of how facet degeneration occurs is that as the disc height decreases with those cracks and loss of hydration, it puts more stresses on the back end of the spine. So you can see as this disc gets smaller, it ends up loading these facet joints in the back. And because of that loading, we see degeneration of the facet joints as well. And you can see on this diagram that on this bottom panel, you can see that instead of having a nice, well-lubricated facet joint, you can see a lot of cracks and bone spurs develop there. And we generically call that facet arthropathy. So if you look at sort of the general epidemiology of spinal osteoarthritis, it turns out that greater than 80% of the population over the age of 55 have some evidence of cervical spondylosis or cervical spinal osteoarthritis, meaning degenerative changes in the neck. By the age of 60, even in patients that are asymptomatic, meaning that they have no symptoms referable to the neck or low back or mid back, that 95% of men and 70% of women have actually at least some finding of degenerative changes on imaging. So the reason why that's an important statement is that it presents basically significant challenges when determining whether, when we evaluate patients, on whether those findings that we see are actually just normal aging versus where they're related to patient symptoms. And I'll go over that in a little bit because it's just very, very common to find these findings. And if you look at the risk factors for spinal osteoarthritis, it's what you would expect, which is older age, female gender, obesity, if you've had a prior spinal injury of some sort, if you're in an occupation that's subjecting to your spine to repeated stresses such as heavy lifting or twisting, there's definitely a genetic component as well where it tends to run in families. If you have some type of a bone deformity, or if you have a metabolic disease that can potentially put you at risk for having earlier spinal osteoarthritis. One of the risk factors that gets missed is that everybody knows the harms of smoking in terms of getting lung cancer, cardiac disease, but it turns out that smoking is actually bad for your spine as well. It does put you at a higher risk for developing symptomatic spinal osteoarthritis. So moving on to the symptoms now. So let's talk about low back pain. It is actually the most common cause of work-related disability in people less than 45 years of age. And it's actually the most expensive cause of work-related disability in terms of healthcare-associated costs, as well as disability-associated costs. If you look at annual visits to primary care doctors or medical specialists, there are 31 million patient visits per year attributed to low back pain in the US, which basically compromises about 3% of all outpatient visits. And if you look at the lifetime prevalence of low back pain in the general population, it approaches 90%. So it's a very, very common problem. if you look at the causes of low back pain, basically there are quite a lot of causes, but if you look at the most common cause, it's basically a strained back, which is basically some type of muscle sprain, ligament sprain. We estimate that that's about 70% of patients that have low back pain. But there's also other causes, such as degenerative processes of the spine or discs. You can also have herniated discs. You can have spinal stenosis, which I'll go over in a little bit. You can also have broken bones from a disease process called osteoporosis, where you have decreased bone density as you age, and that can also cause low back pain. You can have something called spondylolisthesis, which is the medical terminology for slippage of the vertebrae that can cause low back pain as well. And finally, you can have trauma, meaning some type of a car accident or fall that can break the bones that can cause low back pain, as well as something congenital, meaning that you were born with an underlying anatomy that sets you up for having low back pain. So a majority of the back pain, as you can see, is from basically something simple, such as a lumbar strain. In terms of sort of more rare causes, you can have neoplasia or tumors, you can have some type of infection, you can have some type of inflammatory arthritis, such as rheumatoid arthritis, cause back pain. Paget's disease of bone is a metabolic disorder of the bones that can cause back pain. And finally, you can also have Scheuermann's disease, where basically patients progressively develop an angled spine, starting falling forward over time. And finally, you can have low back pain, but it's actually not related to your back at all. It can be a disease of your pelvic organs, such as your kidneys. That can be actually causing what we call referred pain, where it's actually your organs that are problematic, but it's causing low back pain. You can also have something called an aortic aneurysm, where you can have a dilation of a major blood vessel in your belly that causes low back pain. You can also have GI disease. So even this simplified table that I'm presenting to you guys, it's a lot of different causes that can potentially cause low back pain. And the reason why that's important is that at the end of the day, pain is a very subjective symptom that may arise from many different structures that I just went over, such as the ligaments, the joint capsule itself, the discs, what we call the periosteum, which is the lining of the bones itself, the muscles. And that's just limiting it to the spine. I just went over that there's metabolic diseases or other organs in the area that can actually be the pain generator. So it turns out that it's actually quite hard to pinpoint out exactly what the cause of the low back pain is, and that has implications in our treatment plan, which I'll go over. When you have pain going down the arms or legs, or in this case of low back pain going down the legs, that tends to be a little bit more straightforward, because that does typically imply that you have a pinched nerve in your lower back from a neurological cause, and that's a little bit more straightforward compared to just generic low back pain. So moving on to the neck, it's a little bit less common than low back pain, but it's still very, very common. We think that it occurs in a third or more of the general population. For the most part, a majority of neck pain is from neck strain. It's usually very rapid onset, meaning that you suddenly get neck pain, and the symptoms rarely last more than a week. But if you have persistent symptoms of neck pain over a week or two, or you have neurological symptoms such as arm pain, weakness, this should be evaluated further, because it's not quite consistent with the diagnosis of a cervical sprain. And similar to low back pain, there's a lot of potential different causes or different disease that coexist with neck pain. And we won't go over it, but basically just in big categories, there are sort of inflammatory conditions that can cause neck pain, obviously trauma. You can also have metabolic diseases or bone diseases or neuromuscular disorders, all these sort of different possibilities that could be causing neck pain, and that needs to be investigated if the symptoms don't subside. So one of the most common things that we hear is this terminology, spinal stenosis. And I think the best way to think about spinal stenosis is think of it as a more advanced form of spinal osteoarthritis. It's basically a generic terminology that refers to narrowing of the spinal canal. sort of going back to the model, you see that sort of this orange structure within the model denotates where the spinal cord of the nerves are, and basically that's where the nerves are running. And when you have spinal stenosis, it implies that there's narrowing of the spinal canal that's leading to pinched nerves or pinched spinal cord. You can see that on the PowerPoint diagram as well, where you can see that the yellow is basically the normal spinal cord that's running in the spinal canal, and in this mid to lower lumbar spine area, we have advanced spinal osteoarthritis that's leading to pinched nerves. And generally speaking, the symptoms from spinal stenosis actually are much more severe. So in the neck or cervical, when you have cervical stenosis, it can actually cause difficulty walking, weakness of the arms, difficulty with buttoning shirts or loss of hand dexterity, as well as significant arm and neck pain. In the lower back, we call that lumbar stenosis. It can cause similar symptoms in terms of difficulty walking, pain and weakness of the legs. Sometimes it can actually even cause problems with urination or bowel movements. So again, sort of think of spinal stenosis as a more sort of advanced form of spinal osteoarthritis. We briefly went over this earlier on during the lecture, but again, what a herniated disc is that the lining that covers the disc space, called the annulus, develops a tear, and you pop a disc out. And because one of the primary functions of the spinal column is to protect the spinal cord and the nerves, oftentimes when you have a disc herniation, it ends up impinging on a nerve. And the symptoms can be quite dramatic. Typically, it's a sudden onset of stabbing, knife-like pain that goes down the arms and legs, and sometimes that can be associated with weakness as well. So there's a lot of diagnostic studies that we can use to sort of diagnose exactly the form of spinal osteoarthritis that a patient has. We can do simple x-rays, plain x-rays. We can do dynamic x-rays, meaning that we have you bend the spine back and forth or side to side to understand how your spine is moving. We can also get what's called scoliosis x-rays or EOS x-rays, where we're taking a picture of your whole body to see if there's any kind of misalignment or deformity that's there. We can get a CAT scan to take a look at the bones. We can get an MRI to basically look at the nerves and the soft tissues. We can even get a test called an EMG nerve conduction study that looks at the function of your nerves. But one of the cautions that I would like to kind of provide the general audience is that really beware of reading the report line by line. We see this very commonly in our practice, but basically, because of the advent of EMR, it's a great thing. As soon as you get the MRI and the radiologist has read it, basically patients have immediate access to the results, which is great. But just take it with a grain of salt that I just mentioned that having some finding of spinal osteoarthritis is basically normal. Over 90% of the population has some finding. So if you look at this report, this was a lady that I just saw a few weeks back, but I highlighted the areas that could be cause of concern for your sort of non-medical person as they're reading through the report. So if you look at this, there's chronic bilateral L3 pars defects. That sounds very concerning, right? Defect, you have a defect in your lumbar spine. What all that means is that basically this just means that this patient was born with a crack in the L3 bone in the back of the spine. So this is the L3 bone, and this is the pars, and there's a tiny crack there. That can actually be a normal finding. But again, if you read the report without that knowledge, you might think that you have some type of a defect or some malformed spine that can be problematic. If you look at the second line there, the defects demonstrate sclerotic margins. What does that mean? It just means that there's some bone formation around that defect. It means nothing more than that. But again, sort of to your layperson, that could be very concerning. If you move over to the third section I highlighted, there's desiccation of the L3-4 intervertebral disc. Again, I just mentioned that as you age, you lose water in the disc, and that's just a normal finding. And finally, at the very bottom area I highlighted, there's a new shallow left-sided subarticular foraminal disc, which contacts the left S1 nerve root. So again, if you just read that sounds very, very concerning, but all it means is that there's a tiny disc bulge that's not even pushing the nerve, but potentially coming in contact with the nerve root. So if you look at this report line by line, for this lovely lady, you would think that they have a lot of problems in their spine. It turns out that this patient has a very, very mild case of basically low back pain with radiation down the leg that got better with just some physical therapy. So again, just be aware of reading the report because, again, it's the radiologist's job to sort of call out every minor imperfection that they see on the MRI. But it's sort of the clinician's job to figure out which of the findings are relevant and which aren't because it's such a common finding. So then moving on to the treatment. So we'll limit the talk to sort of low back pain, but this does apply to neck pain as well. Basically, non-pharmacologic treatment is the mainstay of treatment. Basically, we're talking about applying superficial heat, massages, acupuncture, spinal manipulation or chiropractic back care, exercises, physical therapy, or some type of sort of a comprehensive multidisciplinary rehab program. Generally speaking, a majority of causes of low back pain will get better with non-pharmacologic treatment. If for whatever reason those modalities are not working, then the next step is pharmacologic treatment or using medications. And basically the most common medication we prescribe or use is non-steroidal anti-inflammatory drugs such as aspirin, ibuprofen, or naproxen. These are actually readily available over the counters. Sometimes we also use muscle relaxants as well, and that can help loosen up the muscles for an acute episode of low back pain. When anti-inflammatories or muscle relaxants don't work, then we move on to the next tier, which is to use a weak narcotic such as tramadol or an antidepressant such as duloxetine. These are typically not considered first line, and I would caution against the use of using these medications right off the bat. For the most part, narcotics such as opioids should really be only used if other treatment modalities have failed. Then sort of moving on to the next tier, there's also sort of non-surgical interventional therapies that we can use. We can use trigger point injections where basically a local anesthetic is applied to a specific spot in the back or the neck that hurts. We can also do what's called epidural steroid injections where if you take a look at this diagram, a needle is introduced into the outer lining of the spinal cord and the nerves, and we inject an anesthetic or anti-inflammatory to help with some of the back pain or leg pain symptoms. And we can also act on the facet joint, so the two joints in the back, by injecting a local anesthetic or potentially even doing what's called a rhizotomy, which targets a nerve that we think causes a lot of back pain. So there's interventional therapies that can be used as well. So when all that fails, that's really when the first time that one should really consider seeing a surgeon. So if you look at sort of the reasons for a surgical referral, there's no consensus guideline that is there in terms of specifically recommending a surgical referral. But the common reasons are, one, cauda equina syndrome. So this is a very severe form of lumbar stenosis where you actually have loss of bowel bladder function, you have groin numbness, you have leg weakness. The symptoms are very, very dramatic. And if you do have these types of symptoms, you should see a surgeon right away. If you have a herniated disc with persistent symptoms that last in excess of 6 weeks, meaning that you have arm or leg pain that really hasn't responded to conservative management, that's been persistent for several weeks, despite injections, medications, physical therapy, that's a good indication to see a surgeon as well. If you have symptoms of spinal stenosis, so that more severe form of spinal osteoarthritis I was talking about, where you have progressive or severe neurological deficits, meaning that you're starting to notice arm weakness, leg weakness, difficulty walking, then you shouldn't wait and see a surgeon you should see a surgeon right away. For that problem I talked about where there's the spondylolisthesis, the slippage of the vertebrae, if you start having progressive or severe neurological deficits from that, including what we call foot drop, where you have difficulty moving your feet or picking up your feet, and when you go upstairs, your foot starts slapping on the ground, you should see a surgeon right away as well. And finally, in terms of for low back pain, if you have intractable low back pain with severe functional impairments that persist for over a year or longer, you should go see a surgeon as well. And the reason why we kind of limit the surgical referrals to sort of the subset proposed here is that it turns out that a majority of the problems that cause low back pain, we don't really recommend spine surgery for. So if you look at sort of this table that I presented earlier, I've underlined the ones in green where it might actually potentially benefit from surgery. And we're talking about the degenerative disc disease or degenerative facet disease, herniated discs, spinal stenosis, the spondylolisthesis, the slippage of the lower back, fractures, broken bones, neoplasia tumors, or Scheuermann's disease. If you tally these up in terms of percentage, it's only approximately 20% of the causes of low back pain that might even be surgical, which is why we limit sort of the surgical referrals to patients that have failed conservative management measures or have specific neurological problems. So if we break down what we do as surgeons, it comes down to basically 4 big categories. So the first category is decompression. We basically take the pressure off of the spinal cord or spinal nerves. In this top panel, you see a minimally invasive lumbar decompression through a tube, where we're basically working through a small corridor to remove the bone and the ligaments and the discs that are pinching on the nerves. Here's an example of what we call an endoscopic lumbar decompression, where we're basically working through a small camera to basically do the same thing, release the compression on the nerves as well. The second thing that we do as surgeons possibly is a stabilization or a spinal fusion. And what that implies is basically placement of spinal hardware or implants to remove or reduce motion. If you take a look here, you see that this patient, on these x-rays, there's a slippage at L4-5, meaning that the L4 vertebrae is slipped in front of the L5. So it's not in one continuity, but basically the L4 is out in front of L5. And what that can cause is basically foot weakness or a foot drop. So what we do in that instance is we basically decompress the nerves like that panel I just showed you before, but we typically stabilize these two because it can move, it can have some abnormal motion. So here you see that there's a slippage before surgery, and once we perform the decompression and place screws, we've reduced the spine and brought it back to the anatomical or normal positioning to reduce the spondylolisthesis. The third thing that we do as spinal surgeons is basically what we call osteotomies or correcting deformities. And these generally tend to be bigger cases. So this is a view of the patient's back. And basically, you are looking at a lumbar spine, lower back. This is the patient's head, and this is the patient's feet. This side's left, and this side's right. And what you can see is that there's a clear curvature to the spine. You see that this patient basically has what we call a degenerative scoliosis, where there's basically a curvature to the spine that's causing tremendous back pain. And what we can do in that instance is that we basically make releases in the spine to basically take the pressure off of the nerves, as well as also loosen up the spine so that it's left stiff. And then once we've loosened up the spine adequately, what you can see is that we can then use the spinal implants, basically the screws and rods that we've placed to basically straighten out the spine. You can see that as we're basically rotating that rod, you can see that the spine is currently curved right now like this. And then as we kind of use the implants, we're basically slowly straightening out the spine, and we're derotating it so that the spine is basically in sort of an anatomical straight position. So these operations do tend to be bigger procedures, but again, sort of that's one of the things that we treat, or one of the potential causes of low back pain. And finally, this fourth category is a little bit more unique, where there are ways that we can do the decompression while preserving the motion. And basically, we're talking about your artificial discs. So this top right-hand panel is basically a patient that has received sort of 2 artificial discs in the cervical spine. And sort of a more controversial area is this concept of what we call a dynamic stabilization, where we actually put in screws, but then the screws and the rods can actually move. And the idea there is that you're specifically limiting the spine to move in a physiologic manner. And this is sort of a little bit more controversial and a bit of a newer technology. So in summary, basically, in terms of the spine, it's really 3 categories and 1 sort of extra categories. We either do a decompression, we perform a stabilization, we perform a deformity procedure, or some combination of the 3. And finally, there's an extra category that's a little bit newer, where we can do some of these procedures and put in hardware, but also preserve the motion via an artificial disc or dynamic stabilization. So sort of in conclusion, if you will, from this talk is that spinal osteoarthritis is a very, very common problem. Basically, nearly everybody gets it at some point in their lifetime. An overwhelming majority of the time, the treatment is non-surgical and requires sort of a multidisciplinary care, such as physical therapy, pain management, physiatrist, chiropractor. That's basically the first line for any type of sort of neck or low back pain from spinal osteoarthritis. And finally, typically, we reserve the surgical referrals for patients with persistent or intractable symptoms if there is neurological findings, such as weakness, difficulty walking, bowel bladder issues. That's when we sort of want to refer the patient to see a surgeon early on. So we have an excellent sort of spine center at our Great Neck location. I'd like to thank you all for your attention. And sort of this is our phone number, our fax number, or our email address. We're happy to review your records to see if a surgical referral is warranted, or if sort of what the best point of care in terms of who the best specialist to see you is. Thank you very much for your time.